Good evening, everyone. So my next topic of the video, which I'm going to discuss with you, is on sulfonamides, that is anti-folate drugs, means which are folic acid metabolism inhibitors, and these are used as the bactericidal and bacteriostatic drugs both. In their own, they're used as bacteriostatic, and when they're used in combination with trimethoprim or pyrimethamine, they are bactericidal. So now I'm going to discuss with you sulfonamides and antifolate drugs. Before I start my video, I want to request you, if this video is useful to you and this is helpful to you, kindly subscribe to my YouTube channel, that is Dr. Nitika Hans Pharmacology Discussion. Now, first, antimicrobial agent effective against pyogenic bacterial infections. Pyogenic means pus related. These are very much effective in pyogenic bacterial infections. Domac used prontosil red dye sulfonamide chrysotile in experimental streptococcal infections in mice, which was highly effective. Prontosil is sulfanilamide, which is the active agent in the prontosil. It has been effective in experimental streptococcal infections in mice, so it was very effective, the sulfanilamide in the prontosil. Now this is the PABA, and the structure of the sulfonamide is very much similar to the PABA, and these are derivatives of the sulfanilamide. N1 substitution governs solubility, potency, pharmacokinetic properties, and phi minor group at N4 is responsible for the antibacterial activity. Now, classification, these have been divided into short acting, intermediate acting, and long acting, and for special purposes. Short acting are half-life is 4 to 8 hours. These are sulfadiazine and sulfasoxazole, and intermediate is 8 to 12-hour half-life, sulfamethoxazole, and longest acting is for the 7 days the half-life is, that is sulfadoxine. Special purposes for topical use, these are sulfacetamide, mefenide, sulfasalazine, and silver sulfadiazine. Pyrimidines, intermediate acting, these are trimethoprim, which has the half-life of 11 hours. Now, this is the mechanism of action of the sulfonamides and trimethoprim. The PABA, which is para-aminobenzoic acid, combines with pteridine and glutamate to form dihydrobutyric acid. In the presence of enzyme dihydrobutyric synthase, which is also folic acid synthase, which gets converted to dihydrofolic acid. And this dihydrofolic acid is the inactive form of the folic acid. And when it gets converted to tetrahydrofolic acid by the enzyme dihydrofolic acid reductase, it is the folinic acid, and it is active component of the folic acid, and which is responsible for the metabolism of the folic acid to form DNA and RNA. This tetrahydrofolic acid it gets converted to DNA and RNA in the cells. And the drugs which inhibit the dihydrobutyric acid or folic acid synthase is sulfonamides. They compete with PABA. And dihydrofolic acid reductase is inhibited by trimethoprim or pyrimethamine in the parasites, like in the treatment of malaria. Resistance to sulfonamides because of mutations that cause resistance can be due to overproduction of PABA. When PABA is more produced, so sulfonamides will not act, because sulfonamides are competitive inhibitors of PABA. The more PABA, like in pus, there is more PABA, so sulfonamides will not act. Production of folic acid synthesizing enzyme with low affinity for sulfonamides. There is production of folic acid synthase enzyme, so low affinity for sulfonamides will be there. Loss of permeability means efflux mechanism is there for the sulfonamides, or other alternative pathway without that pteridine, PABA, and glutamate to dihydrobutyric acid to dihydrofolic acid to tetrahydrofolic acid. That alternative pathway to that in the folate mechanism metabolism can lead to ineffectiveness of the sulfonamides. Sulfonamides' antimicrobial activity is that they inhibit the bacterial growth, reversibly blocking folic acid synthesis. So these are bacteriostatic. Mammalian cells lack enzymes for folic synthesis and depends on exogenous source. Means in the mammalian cells, the folic acid is obtained from the diet, and these are not susceptible to sulfonamides because they lack enzymes for folic synthesis. They get the folic acid from exogenous source like diet. Spectrum of activities, these are effective against gram-negative and gram-positive bacteria, but these are more effective against nocardia and pneumocystis carinii. And these are also effective against E. coli, Klebsiella, Salmonella, Shigella, Enterobacter, and Chlamydia and Trachomatis and other protozoa. Rickettsia growth is not inhibited but stimulated. Formerly susceptible species include meningococci, pneumococci, staphylococci, streptococci, gonococci, but now they are resistant. These are known as antibiograms. These were formerly they were susceptible, but now they are resistant. When organism is resistant to one sulfonamide, it is resistant to other sulfonamides also. This cross resistance is seen. No cross resistance between sulfonamides and other antimicrobial agents. It means inside the class of the sulfonamides, cross resistance is seen, but not to the other antimicrobial agents. Pharmacokinetics, oral and absorbable agents absorbed from stomach and small intestine, widely distributed in tissue and body fluids like CNS, CSF, placenta, fetus. Therapeutic serum concentration is 40 to 100 microgram. Protein count is 20 to more than 90%. Peak blood levels reach by 2 to 6 hours of oral ingestion. And these are metabolized by the acetylation or glucuronidation in the liver. Inactive metabolites, they are excreted in the urine by glomerular filtration. More lipid-soluble members, highly reabsorbed into bile, hence longer half-life. These are more soluble in the alkaline pH in the urine, and in acidic urine, they can precipitate, leading to crystalluria. Means sulfonamides, they can precipitate in the acidic urine, leading to crystalluria. And when we give the alkanizers, that can lead to solubility of the sulfonamides. Treatment, sodium bicarbonate and fluid therapy. More fluid should be taken to prevent the crystalluria, and alkalis like sodium bicarbonate are given to alkalize the urine, because in acidic urine, they can precipitate and cause the crystalluria. Cotrimoxazole is it causes sequential blockage of folate metabolism. It also inhibits the folic acid synthase, and also the hydrofolic acid reductase. Folic acid synthase is inhibited by the sulfamethoxazole, and the hydrofolic acid reductase inhibitor is blocked by the trimethoprim. And this sulfamethoxazole and trimethoprim is given in the combination of 5:1. Firstly, it was given in the concentration of 1:20, means 1 trimethoprim and 20 sulfamethoxazole. But in the blood, it reaches the concentration because of different pharmacokinetics of the two drugs. It reaches the concentration of 1:80. But now we give the drugs in 1:5 as the dose. So once it reaches the blood, it turns into 1:20. Trimethoprim 1 and 20 sulfamethoxazole. Both agents similar half-life 10 hours, optimal synergy concentration 1:20, obtained when given in dose of 1:5. Minimum inhibitory concentration of each component may be reduced by 3 to 6 times. Now this trimethoprim has a larger volume of distribution with lower plasma levels than sulfamethoxazole, and it crosses trimethoprim crosses blood-brain barrier and placenta, is more rapidly absorbed, and trimethoprim is 40% protein bound, and sulfamethoxazole is 65% protein bound. This is cotrimoxazole. Trimethoprim and sulfamethoxazole in the ratio of 1:5 is given. 80 milligram trimethoprim or 400 milligram sulfamethoxazole. When it is doubled, it's given 160 milligram trimethoprim, and sulfamethoxazole is 800 milligram. Cotrimoxazole, it's trimethoprim and sulfadiazine. It's given in the dose of 90 is to 90 milligram and 410 milligram. Sulfadoxine and pyrimethamine, this is used in the treatment of malaria. And it is given in the dose of 500 milligram and 25 milligram pyrimethamine. Dimethoprim and sulfadiazine can be given in the treatment of toxoplasmosis. Cotrimoxazole antimicrobial spectrum overlap. In addition, Salmonella typhi, Serratia. Sulfonamide resistant strains also, it is effective against sulfonamide resistant strains also. Drug of choice for pneumocystis carinii, toxoplasmosis, nocardiasis, and other bacterial infections. And adverse drug effects are cross allergy. There can be cross allergy like carbonic anhydrous inhibitors, thiazides, furosemide, and sulfonylurea. When given with these cotrimoxazole, it can cause allergy. Hypersensitivity like fever, rashes, exfoliated dermatitis. These are the side effects of the cotrimoxazole. Other adverse effects of the cotrimoxazole can be crystalluria, nephrosis, allergic nephritis. Because of the precipitation in acetic urine, it can cause crystalluria. It may cause hemolysis in G6PD deficient patients, and it can also cause aplastic anemia, which is anemia, leukopenia, and thrombocytopenia. Stephen-Johnson syndrome can be caused, potentially fatal, and connectaris. Connectaris is caused because in the body, the bilirubin is attached to the albumin, so it does not cross the blood-brain barrier. But when sulfonamides are given, they displace the bilirubin from the albumin, and sulfonamides combine with albumin, and bilirubin is freed. And this bilirubin, in the newborn baby in which the blood-brain barrier is not developed, this bilirubin can enter the blood-brain barrier, and it can be deposited in the basal ganglia of the newborn baby's brain, which can lead to bilirubin deposition, leading to connectaris. Less severe are the stomatitis, conjunctivitis, arthritis, and hepatitis. Therapeutic uses of cotrimoxazole can be in the UTI because these are cidal concentration in urine. Prostatitis, dimethoprim concentrates in prostate. Hemophilus influenzae and Legionella pneumophila, upper and lower respiratory tract infections like pharyngitis, pneumonitis, trachoma, inclusion conjunctivitis. Topically, it is used 5 to 30% for 4 weeks. Carriers of Salmonella typhi for the enteric fever. Drug of choice for chancroid toxoplasmosis and leishmaniasis. Second drug of choice for the lymphogranuloma venereum, and burns. Topical preparations like silver sulfadiazine is available, which is used in the burns. IV cotrimoxazole 10 to 20 milligram per kg per day. More severe pneumocystis pneumonia, especially in AIDS patient with CD4 cells count less. Gram-negative bacterial sepsis, multi-drug resistant species like Enterobacter, Serratia, Shigellosis, typhoid fever, UTI. It can be given in multi-drug resistant species. IV cotrimoxazole. It's effective in gram-negative bacterial sepsis. Sulfasoxazole, it is the drug which is soluble in the highly soluble, so it does not cause the crystalluria in the acetic urine. It is very soluble in urine. So adequate water intake, rapidly absorbed and eliminated, excellent antimicrobial activity, especially UTI. Topically, it can be given, or it can be sulfasoxazole acetyl, tasteless orally in children, sulfasoxazole acetyl plus erythromycin in children with otitis media, and they cause very less severe areas like hematuria, and crystalluria is not seen because it is soluble in water, in urine. Sulfasalazine is the drug which is poorly absorbed in the GAT and it acts locally in the gut. The sulfapyridine and 5-aminosalicylic acid. Sulfapyridine is responsible for its use in the rheumatoid arthritis as the DMARD, this is disease-modifying anti-rheumatoid drug, and sulfa and 5-aminosalicylic acid is responsible for its high concentration in colon and just anti-inflammatory action. It can be used in the ulcerative colitis, enteritis, and other inflammatory bowel disease. Sulfadoxin is plasma protein bound, is more than 85% extensive tubular reabsorption, hence long half-life, 7 to 9 days, used in combination with pyrimethamine in the falciparum malaria. In falciparum malaria, it is combined with the pyrimethamine and sulfadoxin, and it is used in the malaria treatment. Sulfacetamide is used topically in the eye, very high aqueous concentration, non-irritating to eye. It penetrates the ocular fluids and tissues in high concentration. Effective against susceptible microorganisms is used in the ophthalmic infections, and locular 5 to 20% drops are given. Silver sulfadiazine inhibits growth in vitro of nearly all pathogens like bacteria and fungi, and these are given in the burns topically. They reduce microbial colonization and incidence of infections of wounds from burns, and not used in the established wound infections. Thank you. That's all for sulfonamides or the anti-folate drugs. I hope you understood my lecture. And if you understood my lecture, kindly subscribe to my YouTube channel. Let's just Dr. Nitika Hans Pharmacology Discussion. Thank you. Be happy, be blessed. Happy learning. Stay safe. Thank you.